Okay, so we've talked about invasive ventilation in nauseam. We've talked about non-invasive ventilation. We've talked about blood gases. We've talked about how to interpret them. We've talked about the whole acid-base balance thing. So let's look at a couple scenarios, and let's take all these pieces and let's actually put them together. So when you take your exam, they may give you some questions where you've got blood gases, and they want you to first off interpret the blood gases, and second off they want you to be able to differentiate the appropriate treatment for these patients. So let's start with this one right here. Let's say that you're taking care of an 80-kilo male. When you go to assume care for this patient, he's on a tidal volume of 650. He's got a respiratory rate of 12. He's on an FiO2 of 0.21, so the ventilator is just set at room air. He's got an IE ratio of 1 to 2. He's got a peak inspiratory pressure of 42. He's got a plateau pressure of 32, and he's not on any PEEP at all. When you get your blood gas, you see that his pH is 7.10, his CO2 is 62, his bicarb is 25, and his PO2 is 82. So let's work our way through this. So when I'm confronted with a question like this, the very first thing that I want to do is I want to interpret the blood gas to figure out where we're at. So when we interpret the blood gas, remember we said there were several steps to interpreting a blood gas. The first thing we did was we looked at the pH, the CO2, and the bicarb, and we asked ourselves, is anything abnormal? So when we look there, we see the pH is 7.1, we see the CO2 62, and we see that the bicarb is 25. So is anything abnormal? Well, obviously, yes. The pH and the CO2 are both abnormal. So we know that this blood gas has to be interpreted. We said the next step was we were going to look at the pH, and just based off the pH, we were going to come up with a first name and a last name. So when we look at this pH, we see the pH is 7.10. The first name would be either compensated or uncompensated based on whether or not the pH was between 7.35 to 7.45 or not. And we know that at 7.10 that doesn't sit in the middle, so obviously this pH, the very first name, is uncompensated. Now when we look at the last name, we said the way that we figure out the last name is we cut 7.35 to 7.45 right in the middle. So that would be 7.4. Anything less than 7.4 is going to be acidosis. Anything more than 7.4 is going to be alkalosis. And so when we look at 7.10, we know that the last name is acidosis. So thus far, we're at the end of step 2, and at the end of step 2, we know that this is an uncompensated acidosis. Now the big question is, what's the middle name? And remember we said the way that we figure out the middle name is we look at the bicarb and we look at the CO2 and we ask ourselves which one matches the last name of the pH, which one is acidotic or which one is alkalotic. So when we look at the CO2 is 62. Is that acidotic, alkalotic, or normal? Well, we know that 62 would be acidotic, so we know that matches the pH. What about when we look at the bicarb? We see there that the bicarb is 25. So if the bicarb is 25, we know that that is acidotic, alkalotic, or normal. Well, we know that's normal, right? That sits between 22 and 26, which is a normal bicarb. So we know that's normal. So which one matches? It's respiratory. So first name, middle name, last name, we know that this is an uncompensated respiratory acidosis. Now remember that if the last name was uncompensated, we had if the first name was uncompensated, we had one last thing that we had to do. We had to go back and we had to look at whichever number, the CO2 or the bicarb, whichever one did not match, and we needed to ask ourselves if it was going in the opposite direction. Remember, if it was going in the opposite direction, we changed the name from uncompensated to partially compensated, but if the number that didn't match was unchanged, if it was still within its normal range, then we would say that it was still an uncompensated blood gas. And when we look there, we see that the bicarb is 25. That's within norms. So we know that this patient has truly got an uncompensated respiratory acidosis. Okay, so uncompensated respiratory acidosis. Remember we said the whole reason why somebody would be in an uncompensated respiratory acidosis is because they can't effectively move CO2. And when we talked about CO2, we said that CO2 was the product of minute volume. And we said minute volume was made up of tidal volume and rate. So let's look at our vent settings now. Now we know what's wrong with the patient. We know that they've got an uncompensated respiratory acidosis. Let's look at our vent settings and see what we can change. Well, this is an 80-kilo male, so if it's an 80-kilo male, an acceptable tidal volume would be somewhere between 6 and 10 cc's per kilo as a ballpark. So that means that if we started on the low side, 6 times 80 would be 480. If we started on the high side, 8 times 10 would be 800. So we could be anywhere from 6 times 8, 480, all the way up to 800. Now, when we look at our tidal volume, we see we're on a tidal volume of 650. So does that mean that we can go up on the tidal volume? Initially, you would look at that and you would say yes. You would say yes, we can go up on the tidal volume because it's only 650. But remember, the big rule we said was that we never wanted excessive pressures in the airway. And we said that the big number we looked at was the plateau pressure. Remember, we said that we wanted the plateau pressure to be no more than 30. So when you look, we see this patient has a plateau pressure at 32. So can we go up on the tidal volume for this patient? No, we can't. In fact, what do we need to do? We actually need to go down a little bit on the tidal volume. Okay, so when we talked about moving CO2, we said it was about tidal volume and rate. Well, for this patient, we know we can't go up on the tidal volume. In fact, we had to go down a little bit. So what does that leave us with? We need to go up on the rate. Okay, so when we talk about treating increased CO2, anytime we're dealing with hypercapnic respiratory failure, remember the first thing we want to do is we want to make sure that the patient has an adequate tidal volume. We want to account for the fact that there's a certain amount of air that's physiologic dead space, and we want to make sure that we're providing adequate tidal volume, that we get good lung sounds, good chest rise, we can hear air movement in all of our lobes. And if we've done that, and we can't go up anymore because we're limited by our plateau pressure, then the next thing that we need to do is consider increasing our rate. Now, finally, one other thing that we might actually do for these patients is we might actually increase the expiratory time for these patients. Well, why is that? Well, because remember, a lot of times CO2, the reason why people can't effectively move it is because they're bronchospastic and they need a long time to exhale. So for this patient, the big thing that we could do for this patient is increase their expiratory time, and that would allow them more time to completely exhale before their next breath. Now, there's actually a way to tell if you need to be able to do this. Assuming you have a ventilator that gives you an actual PEEP, not the PEEP that you've set, but that you can actually look and see what the actual real-life PEEP is in the airway. If the patient is auto-PEEPing, if the patient's PEEP is climbing despite the fact that you haven't turned up the PEEP, then that is proof to you that you need to increase their expiratory time so that they have more time to be able to exhale. Okay, let's look at another gas here. You've got a patient who's 70 kilos. She's on a tidal volume of 700. She's on a rate of 14. Her FiO2 is 0.5. She's on 50%. Her IE is 1 to 2. Her peak inspiratory pressure is 46. Her plateau pressure is 40, and she's on 5 of PEEP. Now, when we look at her blood gases, her pH is 7.41. Her CO2 is 38. Her bicarb is 22. And her PO2 is 56. Okay, so when we look at this patient's pH, her CO2, and her bicarb, rule number 1 is anything outside of normal. Well, we see the pH is between 7.35 and 7.45. We see that the CO2 is between 35 and 45. We see that the bicarb is between 22 and 26. So, what would we call this patient's blood gas? We would call it normal. This patient does not have a metabolic abnormality or a CO2 abnormality, but what is concerning on this blood gas is the patient's PO2. That patient has a PO2 of 56, and as a general rule in critical care, we usually don't want the PO2 to ever be less than 60. 60 is kind of like our magic number. We don't ever want the PO2 to be less than 60. Now remember, when we talked about the PaO2, we said that what the PaO2 should be in a nice healthy person is about 5 times what their FiO2 is. So this patient's on 50%, so 50 times 5, this patient's PO2, if they were completely healthy, should be 250. So this patient has a huge oxygen deficit. So when we talk about what kind of respiratory failure is this patient in, we know that this patient is in hypoxic respiratory failure. And remember when we talked about hypoxic respiratory failure, we said that the way that we treat hypoxic respiratory failure is by improving the mean airway pressure. And so when we talk about improving the mean airway pressure, when we talk about actually treating hypoxia, obviously the first thing we want to do is make sure the patient's on an adequate tidal volume and rate. And when we look there, we see that she is on an adequate tidal volume, she is on an adequate rate. And in fact, let's look at that tidal volume for a second. She's on 10 cc's per kilo, but when we look at her plateau pressure, what is it? Her plateau pressure is way up. Her plateau pressure is really high. So what do we actually need to do with her tidal volume? Again, we need to take it down. We need to take her tidal volume down. We need to take her tidal volume down until we get to the point where her plateau pressure is 30 or less. Now, because we're taking her tidal volume down, one of the things that we're going to see is we're going to see a decrease in her minute volume. So what might we see? We might see an increase in her CO2. So by taking her tidal volume down to get her plateau pressure where it needed to be, what do you think we might have to do to keep the CO2 normal? We might have to go up on the rate. And that makes sense. If CO2 is all about minute volume and minute volume is tidal volume and rate, obviously if we get rid of some tidal volume, then we need to give them some rate. But let's go back to this O2 problem. Remember we said that the way that we fix hypoxia is with mean airway pressure. We can consider increasing the FiO2, and we've already talked about the pros and cons of that. But the big thing for this patient is this patient needs PEEP. Right now, this patient is sitting on 5 of PEEP, and with that, she's got a PO2 of 56. So obviously, we need to go up on the PEEP, and we need to increase it. Now, remember we said that for patients with hypoxic respiratory failure, we would go up on the PEEP as much as we could, we would go up on the FiO2 as much as we could, and if the patient was still in refractory hypoxia, then the next thing that we would consider doing for that patient is going up on the IE ratio. So by doing that, we would actually increase our inspiratory time and shorten our expiratory time, but remember that the cost of that is the CO2 is going to go up. And if we have to do that to make the patient's hypoxia go away, then we'll do that. And if we have to see the CO2 climb, then that's okay. Remember, that's permissive hypercapnia. We're more concerned with getting adequate oxygen on board than we are with getting rid of CO2. Ideally, we like to have both of those things fixed, but if we're stuck picking one, we would rather pick getting rid of hypoxia than being afraid of hypercapnia. So again, remember with hypoxic respiratory failure, the big thing we want to think about is the mean airway pressure. The quickest way to improve the mean airway pressure is to put the patient on PEEP. If that doesn't work, then we need to think about inverting the IE ratio. Okay, now let's look at another blood gas here. This is a patient who's got a pH of 7.39, a CO2 of 68, a bicarb of 32, and a PO2 of 82. The story behind this patient is it's a 65 kilo COPDer. The patient's been short of breath for 3 days. The patient's breathing about 20 times a minute. The patient's on 4 liters a minute right now by nasal cannula. And the patient's talking in 4 to 5 word sentences. Okay, so when we look at this blood gas, let's interpret it. So first things first, is everything normal? Well, obviously everything is not normal, so we need to interpret the blood gas. Second question is, looking at the pH, what are the first name and the last name? So when we look at the pH there, it's 739, so we know that that sits between 7.35 and 7.45, so we know the first name is compensated. We know that 7.39 is on the acidotic side of 7.4, so we would call this a compensated acidosis. So the question is, which number matches? So when we look at the CO2, it's 68. So is 68 acidotic, alkalotic, or normal? Well, we know that a CO2 of 68 is acidotic, so that matches. Now, what about when we look at the bicarb? We see the bicarb there is 32. Is that acidotic, alkalotic, or normal? Well, we know that a bicarb of 32 is alkalotic. So which one matches? Respiratory, right? So 7.39, 68, and 32, that would be an uncompensated respiratory acidosis. Now, because the first name is uncompensated, what's the last thing we had to go back and do? We need to go back and look at the number that doesn't match and ask ourselves, is it going the opposite direction? And when we look at the bicarb, we see the bicarb is alkalotic, so yes, it is going the opposite direction. So we need to change the name. This is actually a compensated respiratory acidosis. I'll say that again. This is a compensated respiratory acidosis. So when we look at this patient, what do we need to do for him? Well, the big question is, do we need to do anything at all? A lot of times what people focus on is the CO2. They get all balled up in what the CO2 is. And when you look there, you see the CO2 68. And people go, oh my God, 68, that's a really high CO2. So do we need to do anything about it? Well, remember that the whole focus is not on what the CO2 is and what the bicarb is. I'll say that again. When we're interpreting blood gases, the focus is not on what the CO2 is and what the bicarb is. What the focus should be on is what is the pH. When we take interventions to make a CO2 better or worse, when we take interventions to make a bicarb better or worse, what we should be focusing on is what their impact is going to be on the pH. And when you look at this patient's pH is as close to perfect as you can get. So do we need to do anything about this CO2? The answer is no. We don't need to do anything about this CO2. This patient is already compensated for their CO2 by increasing their bicarb. And when do we see that? Well, we see that in anybody who's chronically hypercapnic, i.e. like a 65 kilo COPDer. So for this patient, the big thing we need to do is we need to recognize the fact that the pH is completely normal, therefore the patient is completely compensated by themselves, therefore we don't need to be doing a bunch of dramatic things to try and get rid of CO2. Now, would it be a bad thing to just arbitrarily control that patient's CO2? The answer would be yes. It would not be a good thing to actually drop this patient's CO2 right now. We look at the 68 and we say, well, we want it to be 35 to 45. Well, in this patient, we really don't want it to be 35 to 45. Remember that this patient has COPD, and because of that, if we take this patient and we put him on positive pressure ventilation, we expose him to multiple bad things. The first thing that we do by taking a COPDer and putting them on positive pressure ventilation unnecessarily is we hyperventilate them, because with COPD, what's the problem? Breathing in or breathing out? Well, we know it's a problem with breathing out. So when I put you on positive pressure ventilation, that doesn't do anything to fix your breathing out. All it does is help you to breathe in, which is just going to cause more trappage of air. Now, when we hyperinflate patients, we actually reduce their cardiac output. We create the potential for a pneumothorax. And in this patient, because this patient's bicarb is already 32, if we were to go and just arbitrarily intubate him and drive his CO2 back down to 40, then what would he have? Well, remember, we can control the CO2 minutes a minute, but the bicarb takes hours to days to change. So if we took this patient and arbitrarily dropped their CO2 back to a nice pretty 35 to 45, we would actually put this patient into a metabolic alkalosis. So for this patient, the take-home point to this is when the pH is normal, then we need to leave the patient alone. This patient right here is obviously doing fine compensating by themselves, and we really have proof with the fact that the bicarb is as high as it is, that this is probably where this patient lives at. This is probably where this patient exists every day. So this would not be a good candidate for mechanical ventilation. Okay, let's look at another blood gas here. You've got a 75 kilo patient. She presents to the emergency room for respiratory rate in the 40s and an altered level of consciousness. She's intubated in the ED and she's put on a tidal volume of 650. She's put on a ventilatory rate of 12. And on top of her ventilator rate of 12, she's overbreathing the ventilator by 14 breaths a minute. So her total respiratory volume, her total respiratory rate is actually 26 breaths a minute. When we look at our other vent settings, she's just on room air right now. She's just on an FiO2 of 0.21. Her IE ratio is 1 to 2. Her peak inspiratory pressure is 26. Her plateau pressure is 22. And her PEEP is 0. Okay, so with that, we draw a blood gas, and what do we see? We see the patient's got a pH of 7.32, her CO2 is 26, her bicarb is 12, and her PO2 is 126. So when we look at this patient's pH, the pH is 7.32, the CO2 is 26, the bicarb is 12, so is everything within normal range? No. So that brings us to our next question. Our next question is, what is the first name and the last name? So when we look at the pH, we know that the first name is uncompensated. And when we look at the last name, we know that the last name is acidosis. Okay, so we know this is an uncompensated acidosis, so the big question becomes, is this respiratory or metabolic? So when we look at the CO2 is 26. Is that acidotic, alkalotic, or normal? Well, we know that a CO2 at 26 is alkalotic. What about when we look at the bicarb? Is it acidotic, alkalotic, or normal? Well, when we look at a bicarb at 12, we see that with a bicarb at 12, we actually have acidosis. So which one matches the pH? It's actually the metabolic side. So it's an uncompensated metabolic acidosis. Because it's uncompensated, we have one last step. We need to ask ourselves, is it truly uncompensated? So we look at the number that doesn't match, in this case the CO2, and we ask ourselves, does it go the opposite direction? And when we look at the CO2 at 26, we know that's alkalotic, so it does go the opposite direction. So we change the name to a partially compensated respiratory acidosis. So again, this is a partially compensated partially compensated metabolic acidosis. I'll say that again to correct myself. This is a partially compensated metabolic acidosis. Okay, so we've got a partially compensated metabolic acidosis. So when we look at treatment for this patient, what do we say we do for patients with metabolic acidosis? Well, remember with metabolic acidosis, we said that the whole focus on treatment is figuring out what's wrong with the patient. So we need to start working down our little algorithm that we talked about previously. So with metabolic acidosis, what do we say was the number one reason for metabolic acidosis? If you recall, remember the number one reason for metabolic acidosis is lactic acidosis. So that would be our first question. Does this patient have lactic acidosis? Well, let's say that we're lucky enough that we actually have the ability to draw a lactate and we get a lactate back and this patient's lactate is less than 2. So it is not lactic acidosis. So then we go on to our next question. Is this patient got DKA? So let's say that we look and the patient has an increase in ketones in their urine and their blood, and the patient also is hyperglycemic. So wham bam, lo and behold, this patient does have metabolic acidosis because of DKA. Okay, so we've made our diagnosis. We now know what's wrong with her. We know that she's got DKA. So the question is, based on what we see here, what are we going to do with her vent settings? Well, remember that this patient is effectively moving CO2 for what reason? The patient's moving CO2 to compensate, right? The patient is getting rid of CO2 because of the fact that the patient is trying to compensate for metabolic acidosis. So the one thing we absolutely positively do not want to do to this patient is we don't want to do anything to take away her removal of CO2. She's getting rid of that CO2 for a reason. She's getting rid of that CO2 to compensate. When we look at the patient's CO2, we know that CO2 is a product of minute ventilation, so we know that that's respiratory rate times tidal volume. Well, when we look at the tidal volume seems fine. That's within our 6 to 10 cc's. But let's look at this rate here. Remember this rate, we said that we had her on the ventilator at 12, but despite the fact she was on the ventilator at 12, she was over-breathing the ventilator by another 14 breaths a minute. Well, what do we want to do about that? Well, the answer is probably nothing. A lot of times, one of the biggest mistakes that clinicians make is taking away compensation. So how would they take away compensation? Well, a lot of times when patients are over-breathing the ventilator, the first thing everybody wants to do is they want to run and grab the paralytics. They're like, I set the ventilator at 12, I want the patient to breathe 12 times a minute. That would absolutely positively be the wrong thing to do for this patient. We don't want to take away this patient's extra breaths. She's doing that for a reason. Remember, the whole basic tenet of mechanical ventilation is you need to set the ventilator for the patient, not the patient for the ventilator. So we certainly don't want to do anything to take away this patient's extra breaths. We want her to get the minute volume that she wants, that she needs. So if we were going to do anything with these vent settings, which again, one of the things that we could do here that would be certainly appropriate would be to do nothing. But if we wanted to do something with these vent settings to make this patient have an easier time, if we were going to do anything, what we might actually do is increase her minute volume on the ventilator. We might actually increase her ventilatory rate or increase her ventilatory her minute volume in the form of increasing her tidal volume. Remember that the only reason why patients breathe is because there's too much CO2 or there's too much acid. That's the reason why you choose to breathe. And so for this patient right now, the reason she's over-breathing the vent is despite your vent settings, there's still too much CO2, there's still too much acid. So we either leave her alone and let her compensate on her own, or if we see that she's starting to flail and fail, if we see that this is too much work for her, then we may actually increase our tidal volume a little bit, increase our rate a little bit, so that she has to do less of the work on her own. And then what we'll see reflexively is we'll see that she will probably come down on her respiratory rate on her own because of the fact that we are giving her more minute volume. So again, the big thing to remember with blood gases is you want to look at the whole picture and remember that you don't want to take away compensation. If she's compensating, it's for a reason. Don't take it away from her, especially with paralytics. And I'll make this statement because it's an important one. Over-breathing the ventilator, as a general rule, is never a reason to paralyze people. I'll say that again because it's really important and it's done so incorrectly so often. Overbreathing the ventilator as a general rule is not an indication to paralyze somebody. Okay, let's look at another blood gas here. We've got another one here. This is a 60-kilo male. He's intubated. He's on a tidal volume of 650. His respiratory rate is 14. He's on room air. His IE is 1 to 2. His peak inspiratory pressure is 46. His plateau pressure is 42, and his PEEP is 0. Now, when we go in to get this patient, his blood gas, he's got a pH of 7.51. His CO2 is 28. His bicarb is 24, and his PO2 is 110. So question number 1, is anything abnormal? So when we look at the pH, the CO2, and the bicarb, we see there's several things that are abnormal, so yes, we need to do something about this. Okay, so as we go through and interpret, remember when we talked about the pH, we said from the pH we were going to get the first name and the last name. So first name should be uncompensated. We're not sitting between 7.35 and 7.45. When we look at the last name, we know that the last name is alkalosis because we're above 7.4. So this is an uncompensated alkalosis. Step number 3 is which one matches. So when we look at the CO2 is 28. Is that acidotic, alkalotic, or normal? We know that that is alkalotic. When we look at the bicarb, it's 24, which is acidotic, alkalotic, or normal. We know that a bicarb of 24 is normal. Okay, so which one matches? Well, it's obvious what matches is respiratory. So this is a uncompensated respiratory alkalosis. So because it's uncompensated, last step is we need to go back and look at the number that didn't match, in this case the bicarb, and we need to ask ourselves, is it going in the opposite direction? And we already said the bicarb was completely normal. So this truly is an uncompensated respiratory alkalosis. Well, what does that tell us? Well, one of the big things that anytime we see an uncompensated respiratory problem, whether it's respiratory alkalosis or respiratory acidosis, if there's not any compensation, the first thing that tells us is that it's probably new. It tells us that it's usually a new onset thing. So this patient probably was not somebody who lives in respiratory alkalosis. This is a new onset thing. Because remember that within hours to days, we'll see bicarb normalization to try and fix the pH. But we haven't seen that yet, so we know that this is probably newer than hours to days. Okay, so we said that this was a respiratory alkalosis. We said this was an uncompensated respiratory alkalosis. So what do we do about respiratory alkalosis? Well, remember that whenever we're talking about CO2, remember we said CO2 was the product of minute ventilation. And we said that respiratory alkalosis was quite simply when we had too much minute ventilation, and thus we were blowing off excessive amounts of CO2. Now remember we said with respiratory alkalosis, the first thing we wanted to make sure of was that it wasn't for a reason, i.e. like the patient was hypoxic. And when you look here, we look at the PaO2 for this patient, it's 110. 110 is certainly a livable PaO2. We can certainly live with the PO2 of 110. So it's not hypoxic, so this is probably just caused by the fact that this patient is simply overbreathing, or in this case on the ventilator, is being overventilated. So when we look here, we see that the patient was 60 kilos. So when we look at the tidal volume is 650. Is a 650 tidal volume appropriate for a 60 kilo patient? The answer is probably not. But in order to say for sure that it's probably not, what would we look at to tell us for sure that this was either too much or was an okay amount of tidal volume? Well, we would look at the plateau pressure, right? And so when we look at this patient's plateau pressure, we see that the plateau pressure is 42. That's way too high. We want the plateau pressure to be less than 30. So what do we need to do for this patient? We need to back down their tidal volume. So as we back their tidal volume down back to an appropriate tidal volume, we'll see the plateau pressures will come down, but what else comes down with that decrease in tidal volume? Well, the minute volume comes down. And if the minute volume comes down, then what happens to CO2 excretion? It decreases, right? So this is the perfect example of overventilation. This patient's whole issue is the fact that they're being overventilated with an excessive amount of tidal volume. If you control this patient's minute volume by turning down their tidal volume or turning down their rate, then we know that this patient will start to have a decrease in how much CO2 they're excreting, and this patient will probably do fine. Okay, Last but not least here, we've got a 70-kilo male. This 70-kilo male was involved in a motorcycle versus train accident. He was riding a motorcycle when he was struck by a train. When the patient presents into the trauma bay, the patient is unconscious. The patient has a substantial head injury, has multiple long bone fractures, has a fractured pelvis, has a blood pressure, we'll say that's 70/30. Let's say the patient's heart rate is 140, and you've got these blood gases. The patient's pH is 7.01, the CO2 is 68, the bicarb is 12, the PO2 is 280, the patient has a base deficit of -8. When we look at our vent settings, the 70-kilo male is on a tidal volume of 500, his rate is 16, he's on an FiO2 of 1, which is 100%, he's got an IE of 1 to 2, his peak inspiratory pressure is 22, his plateau pressure is 20, and his PEEP is 5. So, with those ventilator settings, let's look at the blood gas. So 7.01, 68, and 12, the first question, remember, is everything normal? And when we look there, we obviously see everything is not normal. We're not between 7.35 and 7.45. We're not sitting at a CO2 as 35 to 45, and we're certainly not sitting at a bicarb of 22 to 26. So no, everything is not normal. In fact, everything is abnormal. So with that question answered, then the second question becomes, what is the first name and the last name? So for that, remember, we look to the pH, and we see the pH is 7.01. So we know the first name is uncompensated, because we're not sitting between 7.35 and 7.45. And we know that the last name is acidosis, because we're sitting at less than 7.4. So this is an uncompensated acidosis. The next question becomes, which number matches? When we look at the CO2, it is 68. So 68 is acidotic, alkalotic, or normal. We know that 68 is acidotic, so that matches. And when we look at the bicarb is 12. Is that acidotic, alkalotic, or normal? Well, we know that a bicarb of less than 12 is also acidotic, so we know that this patient has both a respiratory acidosis and a metabolic acidosis. So this patient has a mixed acidosis. So how in the world do we treat that? Well, basically what it comes down to is we have to treat both sides of the coin. We have to treat the metabolic acidosis. We have to treat the respiratory acidosis. So when we talk about treating the respiratory acidosis, that's the fast, easy one to fix. How do we fix the respiratory acidosis? Remember, we said CO2 is all about minute volume, so we're going to increase the patient's minute volume. So minute volume is made up of tidal volume and rate. The first thing we said we typically look at is, can we go up on the tidal volume? And we see that the patient's 70 kilos are on a tidal volume of 500, and they've got a plateau pressure of 20. So can we go up on the tidal volume? Absolutely. We have plenty of space there. Remember, the goal is to keep the plat less than 30. We're only sitting at 20, so we can certainly go up on this patient's tidal volume. If that's not enough to cut the mustard, the other thing that we could do is we could also go up on this patient's respiratory rate. Now let's talk about the metabolic side of things. Remember, with metabolic acidosis, the number one cause of metabolic acidosis is lactic acidosis. And lactic acidosis is because of an inefficiency in oxygen delivery, or there not being enough oxygen supply to meet oxygen demand. When we look at this patient scenario here, does this patient suggest to us lactic acidosis? Absolutely, positively. Patient's got a massive head injury, the patient's got multiple long bone fractures, and the patient's got a fractured pelvis, all of which are things that can very easily cause you to bleed to death. So how do we treat this patient's metabolic acidosis? We treat their lactic acidosis. So we said this patient's blood pressure was in the 70s, their heart rate was in the 40s. Obviously, first thing we're going to do is crystalloids. Very quickly thereafter, the patient needs blood in the form of packed red blood cells, and those are going to increase oxygen carrying capacity. And by doing that, we're going to at least temporarily probably do some things to improve the metabolic acidosis, but really the definitive thing, obviously, for this patient is we need to stop the bleeding, and that's probably going to require that the patient goes to the OR. Now, one last note about this patient that's kind of interesting. This is an actual patient. This patient actually had a huge gradient between their PaCO2 and their EtCO2. This patient's PaCO2 was in the 60s, 68 in this case, but the EtCO2 was only in the teens. The patient only had an EtCO2 of like 14 to 16. Well, why is that? Well, remember that for patients to have a good match between their PaCO2 and their EtCO2, there has to be good perfusion of lungs. And when this patient's blood pressure was in the 70s, there was not good perfusion of lungs. So if you focused on the CO2 of 68 and didn't think about the whole concept of the fact that you have to have perfusion, and you just focused on the respiratory side of things, you might find yourself going up and up and up on the tidal volume and on the ventilator rate and not getting anywhere. Conversely, if you just focused on the EtCO2, you would do absolutely positively the wrong thing, which is to go down on the tidal volume or go down on the rate. Remember, we always want to look at the whole picture, and this patient's whole picture is the fact that the patient has poor perfusion. And so the real treatment for this patient's CO2 lies in the same way that we're treating the patient's metabolic acidosis. That's improving perfusion. So for this patient, what would we do to treat this patient? The big thing is ventilate appropriately, looking at both the CO2 and the EtCO2. We want to find the cause and treat the metabolic acidosis, which we obviously know is poor perfusion. And this is a phenomenal example right here of a patient who is not a good candidate for sodium bicarbonate. If you were to go and give this patient sodium bicarbonate right now, all you would do is you would increase the amount of bicarb that's combining with lactic acid and turning into CO2. Well, you've already got a demonstrated breakdown in the ability to get rid of CO2 because this patient doesn't have any good perfusion of their lungs. Putting this patient on bicarb would just make the situation worse. This is a really good example of a patient who should not get bicarb until we've already improved the relationship between perfusion and ventilation. In fact, for this patient, just improving their perfusion by itself is going to improve the ventilation, and therefore this patient probably does not need bicarb at all. Okay, when we come back, we're going to wrap up the final section of this, which is looking at specific respiratory problems. In the interim, I hope that you have a great day, and we will see you soon.
I'd come for you, no one but